Every year in the United States, approximately 800,000 people have a heart attack. That is one every 40 seconds, and the single most consistent finding across the medical literature on cardiac events, the thing that cardiologists say over and over again when they talk about preventable deaths, is not that people did not have warning signs. It is that they had warning signs for hours, sometimes days, and decided to wait and see. They thought it was indigestion. They thought it was stress. They thought it was a pulled muscle from the gym. They did not want to make a fuss. They did not want to be the person who called an ambulance over nothing. And by the time they decided it was not nothing, it was too late for the treatment that would have saved them to work. This is what a heart attack actually feels like from the inside, and why the gap between the first symptom and the moment you understand what is happening is the most dangerous window in cardiovascular medicine. Your heart is a muscle. Specifically, it is a hollow muscle about the size of your fist that contracts approximately 100,000 times per day, every day of your life, without ever taking a break, without ever getting a rest day, without ever asking for anything in return except a continuous supply of oxygenated blood through the coronary arteries that run across its surface. The coronary arteries are not large. They are relatively narrow vessels, and they are vulnerable to a process called atherosclerosis, the gradual buildup of plaques made of cholesterol, fat, calcium, and inflammatory cells inside the arterial walls. This process begins earlier than almost anyone realizes. Studies of soldiers killed in combat during the Korean War found significant atherosclerotic plaques in the coronary arteries of men in their early 20s. The plaques build up over decades, slowly narrowing the arterial lumen, reducing blood flow to the heart muscle, usually without producing any symptoms at all until something goes wrong with the plaque itself. Here is what actually triggers most heart attacks, and it is not what most people think. It is not the plaque gradually growing until it blocks the artery completely like a drain slowly clogging. That happens, but it is relatively rare. The more common scenario is that a plaque that has been sitting quietly in the arterial wall for years suddenly ruptures. The fibrous cap that covers the plaque tears. The contents of the plaque, the cholesterol and inflammatory material inside, are exposed to the flowing blood, and blood, encountering what it recognizes as damaged tissue, does exactly what it is designed to do when it encounters damage. It clots. Platelets rush to the site and aggregate rapidly. A thrombus forms at the rupture site, and within minutes what was a partially obstructed artery becomes a completely blocked one. The blood supply to whatever region of heart muscle that artery was feeding is cut off, and heart muscle, like brain tissue, does not handle oxygen deprivation well. It begins dying within minutes. This is a myocardial infarction. This is what you are having right now, so what does it feel like? And here is where the reality diverges so dramatically from the movie version that it kills people. In movies, heart attacks are immediate and dramatic. The person clutches their chest, staggers, collapses. It is unmistakable and it is instant. In reality, the most common presentation of a heart attack is so undramatic and so easily explained away by a dozen benign causes that the majority of people who experience it do not immediately recognize it for what it is. The chest discomfort, and cardiologists deliberately use the word discomfort rather than pain because many patients do not describe it as pain, typically begins as a pressure, a heaviness, a squeezing sensation in the center of the chest that feels like something is sitting on your sternum. Not sharp, not stabbing, just pressure. A tightness that does not go away when you change position, does not go away when you take a deep breath, does not go away when you shift in your chair. It just sits there, constant and heavy and wrong in a way that is difficult to articulate. Some people describe it as feeling like an elephant is standing on their chest. Others say it feels like someone is squeezing their heart with a fist. Others say it is more like a band tightening around their chest that they cannot loosen, no matter what they do. The common thread is the constancy. A muscle cramp comes and goes. Indigestion shifts and changes. This does not shift. This does not change. This just stays. Then the radiation begins. The pain or pressure spreads, not randomly, along very specific pathways that are a consequence of how your nervous system maps cardiac pain onto the body surface. The left arm is the classic location, a deep aching heaviness that travels from the shoulder down the inner aspect of the arm to the elbow, sometimes all the way to the wrist and the fourth and fifth fingers. The arm does not hurt the way a bruise hurts or a cut hurts. It aches. It feels heavy. It feels like the arm does not quite belong to you in the way it usually does. Some people describe it as a vague numbness. Others say the arm just feels wrong without being able to specify exactly how. The jaw is another common radiation site, a deep aching pain in the lower jaw that feels exactly like a toothache and sends people to their dentist convinced they have a dental problem while their coronary artery is blocked. The neck, the throat, the back between the shoulder blades, all documented radiation sites, all easily confused with muscular pain, tension, or acid reflux. The nausea arrives, not dramatically. A background queasiness that compounds the chest discomfort and makes you wonder if you ate something bad. Your stomach is not the problem, your heart is. But the vagus nerve, which serves both the heart and the digestive system, is being irritated by the cardiac event, and it is producing gastrointestinal symptoms that feel exactly like food poisoning or indigestion. This is one of the most dangerous features of heart attack presentation, because indigestion is the explanation most people reach for first, when they feel chest discomfort and nausea simultaneously. They take an antacid, they lie down, they wait for it to pass. And while they are waiting, the myocardial infarction is expanding, more heart muscle is dying, and the treatment window that could have limited the damage is closing minute by minute. The sweating starts. Not the sweating of exertion or heat. A cold sweat. Perspiration that appears on your forehead and upper lip and the back of your neck despite the fact that you're not hot, despite the fact that you're not moving, despite the fact that if anything you feel cold rather than warm. This is your sympathetic nervous system activating in response to the cardiac stress. Your body knows something is wrong even if your conscious mind is still explaining it away. Your adrenal glands are releasing stress hormones. Your blood vessels are constricting to maintain blood pressure as your heart's pumping efficiency decreases. The sweat is not a response to temperature. It is a response to crisis. And it is cold because the blood has been pulled away from your skin surface to protect your core. You feel a sense of impending doom. This sounds like a psychological symptom, like anxiety, like a panic attack. It is listed in the medical literature as a genuine symptom of myocardial infarction, a feeling described by patients as a profound and inexplicable certainty that something terrible is about to happen or is already happening. Not anxiety in the ordinary sense, something deeper and more specific, a conviction that arrives without a clear cognitive source. Patients who have survived heart attacks frequently describe it as the moment they knew, even before they admitted it to themselves, even before they called for help. Some describe it as the body's own diagnostic system cutting through all the rationalization and denial and communicating directly that this is not indigestion. This is not stress. This is something that requires help right now. The shortness of breath develops, not because your lungs are failing, but because your heart is. As the infarcting heart muscle loses its ability to pump effectively the pressure in the pulmonary circulation, the blood vessels that carry blood through the lungs begins to rise. Fluid starts leaking from the pulmonary capillaries into the lung tissue. This is pulmonary edema, and it makes breathing feel like breathing through wet cloth. Every breath requires more effort than the last. You cannot get enough air even though you are breathing faster. You sit up straighter, trying to help your lungs expand. You open a window, you cannot understand why you suddenly cannot breathe normally doing nothing more strenuous than sitting in a chair. Here is what is happening to your heart during all of this. The region of myocardium downstream of the blocked coronary artery is dying. Cardiac muscle cells, cardiomyocytes, are extraordinarily metabolically demanding. They cannot survive more than approximately 20 minutes of complete ischemia, zero blood flow, without beginning to die irreversibly. The medical term is infarction, tissue death, and unlike brain tissue or skin or muscle which can sometimes recover function even after significant injury, dead heart muscle does not regenerate. It is replaced by scar tissue, fibrotic tissue that cannot contract, cannot conduct electrical signals properly, cannot contribute to the pumping function of the heart. Every minute of complete occlusion means more dead myocardium, more scar tissue, less functional heart remaining. The treatment for an ST elevation myocardial infarction, the most serious type where a coronary artery is completely blocked, is percutaneous coronary intervention, commonly called a stent procedure, where a catheter is threaded through an artery in your wrist or groin to the blocked coronary artery, and a balloon is inflated to open it, and a metal stent is placed to keep it open. This procedure, performed within 90 minutes of symptom onset, can save enormous amounts of heart muscle and dramatically improve survival and long-term function. Performed 4 hours later, it saves significantly less. Performed 6 hours later, it may save almost none because the damage is already done. Time is muscle. That is the phrase cardiologists use. Every minute between symptom onset and restoration of blood flow is muscle dying that cannot be replaced. And the average time between the first symptom and the decision to call for help in patients who survive to reach the hospital is 2 hours and 20 minutes. 2 hours and 20 minutes of explaining it away, of waiting for it to pass, of not wanting to be wrong, of being afraid of the answer. If the heart attack is large enough or goes untreated long enough, the electrical system of the heart begins to fail. The myocardium that is dying or has died becomes electrically unstable. It generates abnormal signals that can trigger ventricular fibrillation, the chaotic, uncoordinated quivering of the heart muscle that produces no meaningful circulation. Ventricular fibrillation is cardiac arrest. Your heart is still moving, but it is not pumping. Your blood pressure drops to zero. Your brain, receiving no blood flow, loses consciousness in approximately 10 seconds. Without immediate CPR or defibrillation, the damage to the brain begins within 4 minutes and becomes irreversible within 8 to 10. This is the heart attack death that people witness. The sudden collapse, the loss of consciousness, the absence of pulse. But it was not sudden. It was the endpoint of a process that had been announcing itself for hours through chest pressure and arm pain and nausea and cold sweat and a feeling of impending doom that the person kept deciding was probably nothing. The survivors described the experience in ways that are remarkably consistent. The pressure that did not feel like what they expected a heart attack to feel like. The arm that felt strange in a way they had never felt before. The moment they finally decided to call for help and the particular quality of the fear in that moment, not the fear of pain, but the fear of having waited too long. The paramedics who arrived and whose faces told them more than any words. the catheterization laboratory that was cold and bright and efficient. The moment the stent was deployed and the blocked artery opened and the chest pressure that had been sitting on their sternum for 3 hours simply lifted. Survivors described that moment, the opening of the blocked artery and the restoration of blood flow to the starving myocardium, as one of the most immediate and dramatic reliefs of physical sensation they have ever experienced. Like a vice being removed, like being able to breathe properly for the first time in hours. The ones who did not make it waited. They had every symptom. They had the pressure and the arm pain and the nausea and the sweat and the feeling that something was terribly wrong, and they decided it was probably indigestion. They decided to see if it passed. They decided not to make a fuss. And somewhere in the 2 hours and 20 minutes between the first symptom and the moment they finally reached for the phone, the damage crossed the threshold that no stent and no medication and no amount of medical expertise could reverse. And they died wondering if they should have called sooner.